Welcome, everyone. I'm Dr. Scotty Butcher, and this is the Strength Jedi Council webinar series. And I'm very excited to have our presenter today. She's someone who I've met once in person, but talked to a few times, and is a leading expert. I would call one of the worldwide experts on exercise and implementation in osteoporosis. You know, certainly the one that I would trust if I were asking questions around this. So I'm going to be doing a quick little intro here, but I'll introduce Lora and turn the floor over to her fairly quickly here. So just to get things started, quick reminder that please keep your mics on mute, and I'll call on you for questions at the end. And you know, so please hold your questions to the end, or if you want to type them as you're thinking about them, type them in the group chat, but send them directly to me privately. And then what I'll do is I'll moderate the questions at the end and let Lora answer. And if you do want to actually ask your question at the end, then just say I have a question, and then I'll come to you in order, and then you can turn your unmute your mic and go from there. And then just a reminder that we are recording, and this will be posted after the fact on YouTube. So if you don't want to be on YouTube, then keep your video off and don't unmute your mic, and just sit back and listen and enjoy. But otherwise, it will be going up on YouTube. So, all right, let's get into it.
Okay. Do you want me to share my screen now?
No, I've got an intro here, Lora.
Okay.
Okay, there we are. So I don't know, I didn't ask you if you were a Star Wars fan, but I had to pull that in there for the purposes of what we're doing. But hopefully that struck a chord for you.
Yeah.
Good. Okay, well, I am going to turn the floor over to you, Lora. Just a reminder, everybody, keep your mics muted. Yeah, the floor is yours. Go ahead and share.
Okay. You just, all right. So thanks for having me today. It's great to be able to present to the people that you engage in this series. I understand there's a number of talks, so I'm honored to be invited to participate. And I'm going to, I just have to close this. So, there we go. Okay. So today what I'm going to talk about is how we can use exercise to address fracture risk. So people who have osteoporosis or increased fracture risk. And there's a number of things that contribute to fracture risk. So this slide I like to use to get people to think about what are the things that contribute to fractures, whether they're osteoporotic or not. And essentially a fracture occurs when the applied load is greater than bone strength. And so there's a number of things that influence both applied load and bone strength. So when we think about osteoporotic fractures, we think about the main cause being low bone density. And certainly the mass of bone, the material properties of bone, and how that bone is distributed, you know, if you have bigger bones or smaller bones, for example, or the structure of bones can change, those all affect bone strength. So someone who has osteoporosis has already tipped the balance a little bit because now their bone strength is lower, and so they may fracture at a smaller applied load than other people. There's a lot of things that influence applied load that we can also address with exercise, or with coaching on body mechanics, or thinking about motor control, trunk muscle control, and that sort of thing. So for example, we think about our body position or activity, you know, how fast we are walking might influence how we fall. So if someone is walking very quickly and they trip, they're going to put their arm out and they're going to fall maybe on their arm and their hip, so that they're going to distribute the load and not be less likely to fracture. Someone who doesn't have good reaction time, or who's walking more slowly, may fall backwards on their hip, or, you know, fall only on their hip and not on their arm. So things like your orientation during a fall, your body mechanics, your spinal curvature can affect, you know, how your body mechanics. So if you have a hyperkyphotic spine or a curved spine, that can change the loads on the vertebrae, and then you may actually have fractures during activities that, you know, don't involve very heavy loads, but because you've changed your body mechanics, your fractures may be more vulnerable, or sorry, your vertebrae may be more vulnerable. Weak or fatigable back extensors can also change your posture and body mechanics, and also influence the forces on the spine. So if you think about your back extensor muscles, if you put them in a curved position, now they're lengthened. So their moment arms are changed such that you need actually more force to be able to counteract a flexion moment, right? So then that force is actually pulling on the vertebrae, and that could also add compressive load. So there's a lot of things that can actually influence the applied load, both in a fall, but also the applied load to the vertebrae. So we need to think about those things when we're prescribing exercise for people with osteoporosis. Things like local shock absorbers, you know, if you have soft tissue at the impact site, if you're falling on a hard impact surface. As we get older, the integrity of our intervertebral discs can change, and that can influence loading on the spine as well. And I've already mentioned a few things like protective responses, reaction time, sudden onset slippery surfaces, and those sorts of things. So if we think about exercise, what's really great is it can actually influence things on both sides of the equation. It can influence bone strength, and it can also influence applied loads. So I want to talk a little bit about how we think about exercise prescription for people with osteoporosis from both sides of the balance. Oops. Sorry, I went too fast there. So one of the things that you probably should do when counseling or doing exercise prescription for anyone over the age of 50 is understanding whether they are at risk of fracture. And so there's two tools currently available: the WHO fracture risk assessment tool, and this is available online. There's also the CAROC tool available. Now, the guidelines for osteoporosis management, including risk assessment, exercise, nutrition, and drugs, are all going to change in the coming year. So they were supposed to really be released in 2020. They may be delayed, but they will be released in the next year for sure. And so the risk assessment may change, but currently these are the two tools. And so you can actually, what's nice about the FRAX tool is even if you don't know the person's bone mineral density, you can put in all their other risk factors and calculate a risk score. So you might want to consider that as part of your assessment, just understanding someone's risk, because things that might come out, like a history of rheumatoid arthritis or glucocorticoid use, that may result in an increased fracture risk that you might not be aware of, and they might not be aware of. And that may influence your exercise prescription. Several years ago, we came out with recommendations for exercise for people with osteoporosis, and there was two main messages. One was that we recommend a multi-component exercise program that includes resistance training in combination with balance training, in addition to aerobic physical activity. And we recommend against aerobic physical activity to the exclusion of resistance training and balance training. And we selected those words carefully because we heard a lot of messages from epidemiologists and physicians and even patients, you know, that walking is the best type of exercise because it's weight bearing and it's good for bone. And that's not actually what the evidence was telling us. And so we wanted to make sure it was clear that people understood that you had to do all different things. You wanted to combine resistance training with balance training and aerobic physical activity. And we also provided some parameters around that. And a lot of it is consistent with our current physical activity guidelines, in that we recommend strength training and aerobic physical activity, balance challenges, and we also added in exercises for back extensor muscles for posture. And I'll get into that in a little bit. People who have osteoporosis, and particularly those who are at high risk of fracture, probably should also get some guidance on safe movement during activities of leisure and daily living. So those were some of the main messages that came out of the Too Fit to Fracture initiative several years ago. And so I want to talk about some of the underlying evidence and also add in new evidence that's been published since then. So this was actually a really nice network meta-analysis looking at what is the effect, or what is effective for preventing injurious falls. And so they looked at all of the studies that have looked at any intervention and its effect on falls or injurious falls. And they did a network meta-analysis, which is basically when they try to kind of look at different interventions compared to each other mathematically. And what they found was that there's mainly 4 interventions that are effective for preventing injurious falls. Exercise alone, exercise plus vision assessment and treatment, exercise plus vision assessment and treatment and modifying the environment, and a quality improvement initiative that was multifactorial. And you can see that exercise features in 3 of the 4 interventions. So if we think about the effects of exercise on falls, that's on the applied load component of the balance that I showed you at the beginning, right? So if we can prevent falls, we can often prevent a lot of fractures. And then Kathy Sherrington published a update to the Cochrane review looking at the effects of exercise on falls. And they found that overall exercise interventions, when combined together, prevented falls. And then what they did was they did analyses to look at the efficacy of different types of interventions. And I want to caution you against comparing them against each other, because the data are from different studies. So we can't really compare the interventions in terms of, well, this one is a higher efficacy than this one. But what we can do is look at what is the effect of each one on falls. And so balance and functional training is consistently effective. It reduces both the rate of falls and the risk of being a person who falls. And there's high certainty evidence that that's true. Similarly, multi-component interventions that included balance and functional training, as well as resistance training, were also effective. But resistance training alone, there weren't a lot of studies, and it was not effective on its own, which is interesting. And Tai Chi was also effective. Walking and dance interventions were also not, there was low certainty evidence, and there was not good evidence that they were effective. And I'll say that with a grain of salt, because there's also not as many studies as there are for balance and functional training. But if we want to pick an intervention that we know can prevent falls, it's the top 3. Now, if we want to put that in practice, the types of interventions that are used in functional and balance training interventions often have these features. So they're reducing contact with support objects, keeping feet closer together or reducing base of support, balancing on one foot, shifting weight, so shifting to limits of stability, either in static exercises or in dynamic tasks, and then responding to something that upsets your balance, or doing activities that require coordination while moving. So Tai Chi would fit under that, so 3D type exercises and that sort of thing. And so I've got a few fun examples here on the slide. You're all exercise professionals, so I don't need to teach you how to prescribe balance exercises, but these are just some of the features of the balance and functional training interventions that were used in a lot of the studies. Meg, I'm going to do a shout out for Meg Lowry's app, Clock Yourself. If you haven't tried this out, I highly suggest you do. It's really fun. Basically, you visualize a clock on the floor, stand in the middle of it, and it yells out random numbers, and you have to step to them. You can change the speed, you can change how long you do it for, and then you can add brain games. So you can, it'll yell out, not yell out, but it'll say, February, and you have to transpose that in your head to 2. There's aerobic version. There's all kinds of fun settings. So it's a fun thing if you want to use an app for coaching balance exercises with your clients. So if we move now to the bone strength side of the equation, there's a large body of evidence looking at what are the mechanical loading characteristics? Well, sorry, what is the effect of exercise on bone? And the animal studies typically look at the mechanical loading characteristics. And so there's a number of animal studies that have shown that higher loading magnitude, higher loading frequency, and higher loading strain rate, as well as dynamic loading or short bouts rather than long, prolonged bouts of exercise are effective for improving bone strength. When we look at human studies, it's a lot harder because there's not a lot of comparative efficacy studies where we actually compare one type of intervention to another. And so what they have to do is they basically have to look at the individual effects of different types of exercise. And so the types of interventions that have been shown to be effective are ones that involve impact, and often either high or low force activities, most often high force activities. And then progressive resistance training, and then combination training interventions. So ones that often combine dynamic impact exercises with progressive resistance training. And so this is based on, this last one is based on a meta-analysis that was done very long ago and needs updating if anyone needs a project, looking at the effects of exercise on aerial bone mineral density in postmenopausal women. So when they pooled all the exercise studies together, so whatever type of exercise doesn't matter, they looked overall, what is the effect of exercise on bone mineral density? And if you look at the numbers in bold, that tells you the changes in bone mineral density. So in the spine BMD was 0.85% higher in the intervention group compared to the control group. And there was essentially no effect on hip BMD of exercise in general. So that's kind of disappointing. However, what they did was they actually did a similar thing to Kathy Sherrington in that they broke it down by type of activity. And they pooled all the studies that used high force dynamic activities like running and jumping. And they pooled all the studies that did low force dynamic like walking or Tai Chi. And then they pooled progressive resistance training studies, they pooled low weight activities and combination programs. And essentially what they found was high force dynamic activities seemed to have an effect at the hip, but interestingly, no effect at the spine. Low force dynamic had a small effect at the spine, no effect at the hip. Progressive resistance training seemed to have an effect on both. Low weights had no effect, and combination programs seemed to have an effect on both. Now again, can't compare the different types to each other. You would need to do a network meta-analysis to do that properly. And a lot of the studies were not great quality. So we need to try to advance and do better studies. And the other thing I'll mention is this is in postmenopausal women who are heterogeneous for bone mineral density. Most of them do not have low bone density. In fact, a lot of times they screened out people with low bone density. And so it doesn't really tell us what is the effect in people with low bone density. And so my team, so this is a new slide. No one's seen this. It's the first time I've presented it, and I'll walk you through it. But my team did a series of systematic reviews looking at the effects of different types of exercise on bone mineral density in people at risk of fracture. And so the activities are listed on the left side. So we looked at impact exercise, walking, resistance training, balance and functional training, Pilates, and yoga. And FN is femoral neck, TH is total hip, and then lumbar spine is in the right-hand column. And so if we look at hip BMD, essentially what we see is that impact exercise combined with other types of interventions seem to have an effect on femoral neck BMD. There were only 2 studies that looked at impact exercise alone without any other intervention. So often impact is combined with resistance training. It's really hard to study them individually because people often put them together. So there's only 2 studies that looked at impact alone. One was actually not well done. So my confidence in these estimates is not great. But essentially there was a signal at the total hip. We couldn't estimate femoral neck, and there was an effect at the spine. So we think that impact exercise is important, but what we don't know is whether or not it has to be prescribed with resistance training or not. When we look at walking, there was virtually both estimates included 0 in the confidence intervals, which tells us that basically there's low certainty evidence that, and there's probably not a huge effect on bone mineral density. And there was only 1 study and it was underpowered. Actually, sorry, there were 2 studies, one for hip and one for spine, and both of them kind of had the same findings. So very small, if negligible, effects of walking. And this is again in people with low bone mineral density. When we look at resistance training, we see that there's 5 studies, or 4 or 5 studies, depending on the outcome, looking at the effects of bone mineral density on looking at the effects of resistance training in combination with other types of training on bone mineral density. And we see that at the hip, we are seeing a bit of a signal at the femoral neck, the total hip not so much, and nothing at the spine. It's just really interesting. And then resistance training only, we see similar numbers, we didn't even have any data at the spine to look at. So there's very few studies looking at the effects of exercise on bone density in people at risk of fracture. And then we look at balance and functional training, Pilates and yoga. It was either there was no data available, or the studies were so bad that we couldn't even use the numbers. Essentially we see very little effect of these types of interventions, we don't have enough information to estimate the effect of these types of interventions. So if I had to make a statement, I would say probably if we wanted to influence bone mineral density in people who are at risk of fracture, I would say I would probably combine resistance training with impact exercise to try to get the most bang for my buck. There has been a study published recently and we did include this study in our analysis. And this was the LIFMOR trial, and they've published data both in men and in women. And they have really impressive results looking at bone mineral density at the lumbar spine and hip. Now, if you look at the picture on the left-hand side, you'll see that the control group lost lumbar spine BMD and the intervention group had a big increase. And then if you look at the next number, it's femoral neck BMD, and you can see that the control group lost bone density and there was not that much change in the intervention group, a very small increase, but the delta was significant in both cases. So this is very encouraging, suggesting that we might be able to have an impact on bone density with combined in high intensity resistance training and impact training. And again, they've combined it, so now we can't tell whether it was the impact training, the resistance training, or whether or not you need both to have an effect. So it'd be really nice to separate that out. To know, do we need to do resistance training in combination with impact training to get these results? The other thing I'll mention is that the group that was studied they did screen a lot of people, and they did screen some people out. So they were screening out people who had disc issues, arthritis of the spine that would potentially be risky. People had really poor range of motion in the shoulder, so they couldn't do overhead presses. They screened out a bunch of people for MSK issues and those sorts of things. So, and the average age of the population was 65, which is on the younger age of older adults. So the only thing the only caveat I'll say is, we may not be able to do this type of training in all people with osteoporosis, because there are going to be people who have these other comorbidities or who may be at higher risk where this type of training may be challenging to implement. But we can start them at where they're at and figure out how we can progress resistance training in this group. So my caution in this is that I don't think that the people in this study were the real high risk people. I suspect they were women with low bone mineral density who were otherwise fairly fit. And in those people, we can start them on a resistance training and a high impact training journey and progress them over time. And I think that you may see positive results as they did in this study. So what this tells me, and it just sort of encourages the idea of the principle of specificity. So when you think about prescribing exercise, we have to figure out, what is our primary goal with the person in front of us, and what is the risk relative to harm, and where are we going to start our focus? So if our focus is, that the person has very low muscle mass, sarcopenia, low muscle strength, we're going to go to moderate and high intensity progressive resistance training and ensure they have adequate protein. If our focus is fracture risk, we want to combine resistance training with impact exercise and balance training to both affect fall risk as well as fracture risk. And in some people, we may need to prioritize preventing falls over fracture risk if they have really poor gait or mobility issues or balance issues, or if there are reasons where impact exercise or high intensity resistance training may not be safe, then we may need to say, okay, well then our priority is going to be preventing falls in this group, or preventing muscle loss and preventing bone loss. If someone's issues are endurance and stamina, so we see that, in people who have, conditions like COPD, other things, we may need to focus on conditioning type resistance training or aerobic physical activity, rather than focusing on, higher intensity resistance training or impact exercise. And if posture is an issue, I would encourage you to screen posture in all of your clients and think about, at minimum, doing some coaching on bracing and alignment, and potentially also encouraging them to do exercises for back extensor muscles. So, and this is a really nice study that really highlights that principle of specificity. So this was a study, it was published in the New England Journal of Medicine in 2017, and they've since published other studies from this work. And what they did was they took adults over the age of 65 who were obese. They have a control group that got nothing, and then they had 3 other groups that got a weight loss program. So they were nutrition advice, and then they each got a different exercise intervention. So one got an aerobic training intervention, one got a resistance training intervention, and one got a combination training program, aerobic and resistance. And so if you look at the pictures, you can see that the findings change depending on what outcome you're looking at. So if you look at peak oxygen consumption, the groups that got aerobic or combination aerobic and resistance tended to do better than the resistance training program. If we look at lean mass, the group that got aerobic and combination training actually lost lean mass, whereas the resistance group tended to preserve it a little bit better. And remember, these are all people who are on a weight loss program. So you expect them to lose lean mass, you expect them to lose fat mass. But the resistance partially preserved the lean mass in that group. And the same was true for bone density. So people who are losing weight are going to lose bone. And this is something that concerns me when we think about, a lot of people have, issues about, gaining weight as they get older, and the way that their body changes. And so they may, perpetually be on a diet, and this may actually exacerbate bone loss. And so we need to encourage people to consider what they're doing to prevent that. And we see here that the aerobic group and the combination group tended to lose more bone than the group who did resistance training. And strength was preserved in the resistance training in the combination group, and aerobic increased, and the aerobic group pretty much stayed the same. So it just shows you how specificity of training is important, and that we want to try to do combination interventions to maximize our benefits. So if we want to think about implementation, their impact exercise is something that we can consider implementing. And the first thing I would say is thinking about the risk, whether or not, if someone has moderate or high risk osteoporosis, spinal osteoarthritis or knee osteoarthritis, balance impairment, we really need to think about, whether or not the benefits of implementing this type of exercise are going to outweigh the risks, and think about very careful progressions, or limiting to lower impact using a support object and that sort of thing. And it's possible that in most people, or I would argue all people, you really might need to start with the progressive resistance training to build strength first and do some conditioning before you ever implement impact exercise. At least that's what I would do. So starting with conditioning muscles, being used to those higher loads with resistance training, and potentially some power training or rapid contractions without actually doing the impact part. And then thinking about progressing by adding, things like heel drops, foot stomps, then low drop jumps or jumps, but making sure that we focus on soft landings, and then progressing towards the higher impact stuff that they were doing in the Lift More trial. And my understanding of the Lift More trials, they actually used this approach where they did this type of progression. They started low and progressed them. And the guidelines, the Australian guidelines for impact exercise suggest 3 to 5 sets, 10 to 20 reps, 1 to 2 minute rest in between. If we think about incorporating strength training, I personally am a strong advocate of using functional strength training, functional multi-joint strength training exercises, because these are the types of things we can convince people the importance of this, because we can relate them to activities that they do in their daily life. And so thinking about every exercise fits the category of push, pull, squat, lunge, hinge, carry, or reach, and making sure we represent these movements in our training programs. I don't really need to get into this in detail, I don't think, with this group, because you all know how to prescribe exercise, but we sort of try to characterize things in the folks we work with. A lot of them tend to be on the frailer side or have multiple conditions. So we think about starting them, you know, at a seated or level 1, depending on their balance and that sort of thing. And choosing, everybody does a squat, but we find where on the continuum is the person I'm working with. Are they just at a sit to stand level, or a box squat, or maybe we're already doing body weight squats or progressing them to weighted squats, you know, if they're quite fit. But thinking everybody does a squat, but where on the continuum are they? And the same is true for hinge, for push-ups, for all of those movements. And so we think about the continuum, but everybody does some form of that type of exercise. I mentioned posture, so I think in everyone we want to look at posture, but we want to think about coaching people on alignment as the first step before we even get into strength training. So thinking about, you know, okay, when you're in standing, you root your feet, point your toes forward, have some tension in your glutes to have some external rotation in your hips, so that sets your pelvis. Then we hug our hips in, take a nice diaphragmatic breath to create some tension in our abs, and then keep that tension there. Spreading our collarbones, the head of our arm bone should be pointing out away from our body and back. So maybe we can all just take a break here and think about, imagine that your collarbones are wings and you want to just spread your wings, right? And so it's a gentle thoracic extension, and then thinking about externally rotating our shoulders, align our head over our shoulders, relaxing our face, and then tongue to the roof of the mouth. If we then think about coaching that and teaching people postural awareness, both during exercise, during daily activities, we can sort of have this become a habit. But this piece should, in people with osteoporosis in particular, should be coached, because this will help people adopt the proper bracing that they need during exercise to support their spine. And then we think about, you know, now moving to exercise. So now if we want to think about exercises for posture, there is evidence that exercises that focus on back extensor strength or endurance, and there's a bit of an argument on whether we should focus on strength or endurance. I'm on team endurance. But anyway, if we do exercises for back extensor muscles, it can actually have an effect on posture measured via the Cobb angle. And this is a study by Wendy Katzman. It's called the Sheaf Trial, if you're interested in looking it up. Really interesting study. I often get questions, you know, can I do exercises for my stomach? So we see people who have hyperkyphosis or poor posture and their stomach tends to protrude, and they think, you know, they want to reduce the fat there. And I say to them, well, let's first work on your posture, because that can actually influence that area. But yeah, sure, we can choose exercises to work on your core or your stomach. I tend to focus on ones that don't involve a lot of flexion. So I avoid the curl ups and the sit ups in people with osteoporosis. Some people can do them, but it would depend on their risk. And I would often start with, you know, more plank type exercises. And I might then progress them to a curl up if I feel they could do it safely. But it's not something we know, right? We don't know what the risk of doing that type of exercise is. So I would tend to, you know, focus on bracing first, then progressing to some sort of plank, then event and lateral planks, and then thinking about more dynamic movements like stir the pot. I also really like the plank to push up, because it is good for conditioning and good for our upper body strength as well as core strength. And we think about exercises for back muscles. I have sort of two categories. You have the appendicular muscles of the back, because a lot of people who have hyperkyphosis or poor posture will tend to have scapular protraction and medial rotation of the arm. So we want to think about strengthening the scapular stabilizers and mobilizing pectoral muscles and medial rotators. So I have some links here for some stretches. I'm not a big stretch fan. I prefer mobilization exercises, so a lot of mine will focus more on that. But the idea of these types of muscles like this, when we think about the appendicular muscles of the back, this is where our goal might be strength or power. So we may use, you know, less than 6 RM or an 8 to 12 RM, you know, for our prescription. And then combining that with, you know, mobilization of things that restrict, you know, good posture. But then if we think about the back extensor muscles, those typically are comprised of endurance type muscle fibers. And so I personally am on the encouraging endurance of these types of muscles. So I would tend to go with either holds, isometric exercises, or, you know, the 12 to 15 RM intensity range. And we focus on both strengthening thoracic and lumbar extensors, as well as working on mobility of the thoracic spine. So those would be the two goals that I would think about, while also, you know, combining that with the addressing scapular protraction and forward head posture. And so we typically use the bird dog, or but there's a number of other, I have another slide actually, it goes through a progression, but also thinking about what the lumbar spine looks like. And in people with osteoporosis, you may see either increased or decreased lumbar lordosis. They will often compensate either way to compensate if they have a thoracic hyperkyphosis. And so needing to look at what you see and then stretching or mobilizing or strengthening the muscles to try to get a more neutral posture. So there's a number of ways we can target the back extensor muscles. We start often with supine lying and then add exercise in the supine position, especially if people have hyperkyphosis or pain due to vertebral fractures. If someone has a hyperkyphosis, they will need a small pillow to be able to lie flat, but otherwise I would not use a pillow. Then we can start adding, you know, supine presses or extensions. So we do like an arm and leg extension in supine, or a gentle chest lift, and that's where we think about not sort of hyper extension, but more of a, you know, okay, spreading the collarbones and, you know, allowing your shoulders to feel heavy in the floor and that sort of thing. Or doing a leg press into the floor for lumbar extensors, or a leg lengthener. We could then progress to a prone trunk extension. So Rashid Snaki's done some work looking at prone trunk extensions, even with weight. I would do it over a pillow or a bolster, just so that we're maintaining a neutral lumbar spine, and then extension through a small range of motion. Then you could progress to doing it in standing once the person's got good control. So doing it in standing, or doing it quadruped, so like the bird dog. I find a lot of people don't actually have good trunk and balance control to go right into a bird dog. So I will often regress, work on it in supine or standing, and then progress to the quadruped. And some people, you know, if you need to do it seated for a variety of reasons, you can still do things like what I have in the picture there, where you have a ball or a pillow and you have them sort of extend, or they can put their hands behind their head and do, you know, some thoracic mobility over the ball. So there's a number of ways to incorporate back extensor muscle training, and I would encourage you to consider it, especially if you're working with people with osteoporosis. The other side is the physical activity piece. So we know we can use exercise to have an effect on fall risk, on bone marrow density, on posture. But people with osteoporosis will often have questions about safety of different types of activities that they like to do. And so, you know, I will often get questions, you know, can I do yoga? Can I lift my grandchild? Can I still golf? Or, you know, I had one woman say to me, I know the exercises I should do, but they're boring, and the things I like to do, I can't do anymore. Because we need to think about the language that we use with people. So there are times where we need to restrict activities because of risk, or we need to modify them. But we want to make sure that we're not creating a disincentive for physical activity. So we want to use language that encourages physical activity, like, you know, but also helps people understand the risk or the why we're modifying things. So we might, you know, we first wanting to understand that we know that, you know, even in high risk people, exercise can prevent falls. And there's very little evidence that exercise is not safe, and it can reduce pain and arthritis. So we want to address fears. People often have fear about pain, about falling. But we might need to think about, you know, alignment first. So, you know, we're not starting the lift more trial in everyone. We need to think about, you know, working on alignment more than intensity initially, or starting at moderate intensity, either for resistance training or aerobic physical activity. And in people with osteoporosis, particularly high risk, but I would say, and you know, even in people who are moderate risk, thinking about, okay, is the activity that they're doing rapid, or does it involve rapid, repetitive, sustained, weighted, or end range flexion or twisting? And is there a way that I can modify it so it's lower risk? Does it have to be rapid or repetitive? Does it have to be end range? Can I change it so that I'm doing better bracing of the spine and maybe not going to end range, or I'm not weighting the spine and they're not braced, or they're not weighting the spine during flexion, for example. And also knowing that transitions between exercises and daily activities are just as important. So thinking about coaching good bracing and alignment techniques during transitions in and out of bed, during putting shoes on, lifting groceries, those sorts of things. In fact, one of the trials looking at exercise and vertebral fracture, a woman fractured a costal cartilage rolling from supine to prone. And so it wasn't the exercise that was a problem, it was actually the transition. So thinking about coaching good movement during those transitions is also important. We often encourage people to consider supine lying if they do have pain, to promote passive extension of the spine and unloading of the spine. So if thinking about those physical activity recommendations, they may vary depending on the person in front of you. So the first thing I would think about is, do they have a vertebral fracture? Because that automatically puts them at high risk. Or do they have a spine fracture? Or do they have multiple fractures? Are they on osteoporosis therapy? Because that's going to decrease the risk. What is their current health and physical function? What is their activity history? Have they done this activity for years with no injury? And how much do they want to do it? Because that's going to influence my decision making. So if I have someone who has skied for years and they're 70 years old and they diagnosed with osteoporosis and they ask me if they can keep skiing, I would say, well, you might want to wear hip protectors and stick to the blue runs and avoid the snowboarders, but understand that if you fall, you're at an increased risk of fracture. So do what you can to reduce your risk, and you have to balance how much you want to do it with the risk, and do what you can. So have a conversation about that rather than immediately saying no. If someone told me they wanted to take up skiing and they had osteoporosis, I'd probably say choose another sport. So a person who has been doing it for years might have the motor control to avoid falling and reduce the risk. I met a woman who her exercise was she was a black belt in Aikido, which is a martial art. And she did it 4 times a week and competed. And, she was told she had osteopenia, which is not osteoporosis. And her doctor told her she had to stop. And she was very upset by that. But she went to a physical therapist and they had a conversation about her desire, her activity history. And they decided, okay, probably stop competing and don't spar with novices because they don't know how to throw you. But otherwise, you're probably a better faller than anyone else, right? Because you've been doing it as part of your sport. So having that conversation is really important. And people who have osteoporosis, but they're not high risk, or they don't have a vertebral fracture and they have a strong history or desire, is there a way you can modify the activity so that they can do it? Can they do it spine sparing? Can you find a lower intensity version and slowly progress them so that they can learn good trunk control body mechanics while they do it, and make sure that they're not going to fall? We may want to avoid or restrict high impact sports, high fall risk or contact, and instead do low impact or slower pace type activities. If someone has a vertebral fracture, they have gait and balance difficulties, hyperkyphosis, or pain, this is where some activities, the risk may outweigh the benefit. So if someone told me they had multiple vertebral fractures, I would be very cautious doing loaded deadlifts in that person, just because, unless I was absolutely certain they could do them with good form. But it would take me a while of coaching mechanics and that sort of thing to get to that level of confidence. And that's me. Or if they have gait and balance difficulties, we need to think about their fall risk. They may need to ensure that the instructor for a class or whatever they're doing knows how to teach them what they need to do, or knows about osteoporosis. They may need to get help beyond light activities of daily living, and avoid long periods of sitting. The recommendations we give may need to vary based on their clinical presentation and also the skill of the person working with them, right? Ultimately, you have to use your clinical judgment as to whether or not something is safe for someone. So, I'll give you an example. We had a study that we just finished, and it was in pre-frail older adults, and there was an 80-year-old woman who'd had a history of hip fracture, but she was very fit, very active, very keen to try anything. And, we had her eventually towards the end of the study doing goblet squats with, 10 pounds, and she was, doing great. And she was probably the fittest of the bunch that we were coaching. And on the very last day of training, I transitioned her from doing just kind of lunges forward without any weight, or she was to lunges on a step. And I'm not, like the fitness steps, but without any risers, like just a 1-inch step. And she was doing a lunge onto and off of that step. She lost her balance and fell and fractured her pelvis. And again, this is a person who I wasn't there, but it was being coached by other people, and it, you have the person in front of you and you think they're fit and you think they can do it, and they're doing all kinds of other things, but we still need to be cautious. It was just, she didn't quite have the motor control and the muscle strength to do that. And it was a fall that could have happened anywhere, but it does happen. So we need to be aware of the person in front of us. I get the question, how much can I lift a lot? And my answer is, it's not how much, but how. And being able to have coach people on spine sparing. And ultimately, in people with osteoporosis, I tell them that they should avoid very heavy loads. And if they're not sure, they should get help. And then if we think about people with vertebral fractures, there's very limited evidence on what we should do with them. In people with acute vertebral fractures, most guidelines, or there's not even guidelines really, but most people, if you ask them, we would say that some people will need bed rest. Most will need some activity limitations because of pain. And these are painful ones. Some vertebral fractures, people don't even know they have them. I'm talking about the ones that actually are symptomatic. Some will need analgesics. Bracing has been used. Some studies suggest it works and some don't. The quality of evidence is very low. Some suggest that modalities can help. We often recommend supine lying, intermittent supine lying. And there's one study that's used interferential and horizontal electric therapies. I don't know anything about that, so I'll leave that to you. But modifying activities. So again, coaching, bracing, coaching alignment, and then thinking about how to apply that to different activities is probably very important. Once we get to the chronic stage, if they still have pain due to vertebral fractures, things like analgesics and that kind of stuff are probably not going to work. And this is where we need to address deconditioning and deformity. So back extensor muscle weakness and hyperkyphosis, problems with alignment, body mechanics during activities, and then building endurance for daily tasks and walking. So intermittent walking would be a good strategy, for example. And I've got some examples of, progressions of different types of back extensor exercises there. We did a Cochrane review looking at exercise after a vertebral fracture. There's not very many studies. There are some adverse events. So again, knowing the person in front of you, coaching, all of the adverse events occur during transitions. So rolling, dropping a weight on a foot. Very few studies looking at falls. We can say that exercise does improve mobility. So that's encouraging, and some studies suggest that it can improve quality of life. As I mentioned, if someone has pain due to vertebral fractures, we encourage supine lying, just in the Shavasana position, 15 to 20 minutes, 2 to 4 times a day, to unload the spine and promote passive extension of the spine. And when they're beyond the acute stage, they can add exercises for back extensor. So here I have the arm lengthener exercise demonstrated. And we usually suggest they hold it for 3 to 5 seconds and repeat anywhere from 3 to 12 times, depending on, how much pain it causes or what their tolerance is. We get a lot of questions about yoga. People love yoga, and they want to know, can I do it safely? And my suggestion is to look for an instructor that knows about osteoporosis and knows how to modify activities. Focus on control rather than intensity and quick movements. If you're doing an exercise that requires balance, make sure you stand next to a wall or have a support object, and modify or avoid any yoga poses that involve full bending or twists, especially twists during sitting. Full hip rotation, weighted movements, combined sitting and twisting. Oh, I already said that, sorry. Rapid or repetitive movements, and also being mindful of the transitions. So these are some examples of postures that I would avoid if someone had osteoporosis. So ragdoll, saw, plow, pigeon, spinal rocking, forward fold where you're hanging off of your ligaments, those sorts of things. And I love yoga, so I'm not a yoga critic at all, but there are things that we need to be mindful of in people with osteoporosis. I had someone tell me once that their mother lost their balance during a yoga class and fractured her hip. So these things do happen, and so we just need to be mindful of them as we're coaching our clients. We did a lot of work with Osteoporosis Canada to develop some KT tools. They are available free online. If you're interested, just Google Too Fit to Fracture. I'm hoping we can develop some new tools as well as the new guidelines come out. If there's time afterwards, we can maybe discuss, what's my time like, Scotty?
You are, you're looking at about 50 minutes now, maybe about 45 minutes. So yeah.
So I'll leave this, you think do you want, maybe I'll stop, or we can do questions, and then if there's time, I can go through the case study. How about that?
Sure, let's do that.
So this is just a quick summary of some of the stuff that we're working on now. So we just got funded to do a trial looking at resistance training in people with low bone mass, and we're going to do both moderate and high intensity and a control group. We've had to put that study on pause because of COVID-19, but we hope to start in the next year. I have a few fun student projects. We're doing some remote coaching of exercise and hopefully developing a tool for people with vertebral fractures. So stay tuned for that. Canada's physical activity guidelines, or actually I should say 24-hour movement guidelines, are going to be released in 2020, and I had a small part in that. So look for that. That'll be in October. And I'm working with Osteoporosis Canada on the exercise guidelines, and so those will also be released sometime this year. So I guess to summarize, I like to use the words of Yuichiro Miura. He's 83, or he was 83 when I read the article on him. And he reached the summit of Mount Everest 3 times after the age of 70. And at 80 became the oldest person to reach the summit after 4 heart surgeries. And the quote, it was, "You need a target, however big or small, and build your health and fitness towards it." So thinking about when you have a client with osteoporosis, understanding their risk and the potential benefits you're trying to achieve with that person, and thinking about the targets might be bone strength, posture, balance, or muscle endurance or capacity to do a movement or exercise. And so narrowing those goals and then figuring out where they are at and progressing them. So not trying to achieve the Lift More trial or achieving high impact exercise in everyone, but figuring out where they're at, what their risk is, and progressing them towards the benefits they're looking for, and thinking very much about specificity when you're doing that prescription. I like to think that all programs should consider functional strengthening, posture awareness and exercise, balance and endurance activities, and if you're going to do impact, thinking about conditioning them first. And so those would be my practical takeaways. And these women embody the programs that I'd like to see in everyone, but a little bit of each of these women in everyone. So Ernestine Shepard being in 2010 was the world's oldest competitive bodybuilder. Sister Madonna Buter at age 86 had completed 360 triathlons and 45 Ironmans. And Joanna Quas performed a gymnastics floor and beam for a Guinness World Record at the age of 86. So if we can combine impact aerobic and strength training, that will be the best we can do. But we really have to figure out where we're at and start where we're at. So I'd just like to acknowledge my team. They've done a lot of the work that I'm presenting today. So I'll stop there.
That's absolutely fantastic, Laura. Thank you so much for that. Lots of really good practical information, and yeah, I'm just really, really happy for your combination of both the research and the practical side. I know that's usually the biggest thing when people are wanting to know information on this. It's not just about the research, or it's not just about practice. And so thank you for blending those and bringing those in. So if anyone has questions, go ahead and type them in the group chat to me, and I can moderate them. If you want to actually come on and talk to Laura, just say me and in the group chat, and I'll come to you and you can open your mic. For now, there's just a quick question. It says, can you please take to the summary slide? So can you go back, I guess, into sharing your screen?
Yes.
Thank you. And then Harish, I assume you have a question. You can come on. You can come on, unmute your mic and ask your question if you like.
Okay, I think it was this one.
Harish, do you want to unmute and let us know what you want to know?
Yeah, I missed the last point, conditioning before the impact. I wasn't sure what it was. Just want to make sure.
Yeah, so impact exercise is often recommended for people with osteoporosis, and the concept of impact exercise can go walking is an low impact exercise, running is a bit higher impact, and then you have like jumping and things that are even higher. And some research suggests that we need sort of moderate to high impact to have an effect on bone. But one of the challenges is if we're taking people who are deconditioned and starting an exercise program, I wouldn't start with impact exercise. So I would want to make sure they're sufficiently conditioned, either with muscle strengthening or working on muscular endurance even, or muscular power. So I would probably just start with your basic muscle strengthening exercises for lower extremities before I would start introducing like jumps and things like that. So I'd probably start with some basic strength training. Then I might do some adding some speed to that movement. Right? So, instead of doing like a squat, maybe I'm going to do it a little bit more quickly, or if I'm doing, calf raises, doing it a little bit more quickly and adding some speed, and then maybe starting to add the impact, just so that the person doesn't hurt themselves. And so I'll give you a good example. Again, this other study we just did in pre-frail people, we had an impact component, but really we had her doing kind of little foot stomps, right? Just to kind of work on, conditioning. And she had a pre-existing Achilles tendinopathy, and she didn't tell us, and we didn't know. And so then we started doing calf raises, and immediately she was uncomfortable. And so, and we had already even done some preconditioning prior to that. And so just, knowing when and how to progress impact exercise. It's not, I just want people to understand that you can't just sort of start people with impact exercises. You need to do some conditioning first.
Thank you.
Yeah, great question. That's good. So if anybody else has questions, feel free to add them to the chat. I have a couple that I just want to get things moving as well. So you say you're not a stretch fan, but you're more of a mobility fan. I certainly, I'm on board with that. Can you just maybe outline why you think that?
I can't provide a really good scientific rationale. Of the studies I've read, some meta-analyses that look at stretching, and long-term, they don't seem to have an effect on range of motion. I know that there is some evidence for the benefits of stretching for other reasons, and there's some experts in Australia that do some work. I do think a lot of the work is not that great quality that has been done. I think not saying that guy, I'm sure that guy's work is quite good, but in general, a lot of the work hasn't been done. So there's not a lot of strong evidence to say that, yeah, stretching is going to have a huge impact. And the other reason, the way I think about it is like, you can try to lengthen a muscle, but then it doesn't really help you when you're actually trying to do activities. So I would prefer to do mobility work through the range of motion and try to improve my range of motion during the types of movements and range that I'm going to do in practice. So I tend to prefer, also I've seen that it works better for me. So I've been prescribed stretching exercises and actually had injuries as a result. Whereas when I do mobility work, I find it's more effective for me. So it's partly anecdotal and partly based on research, although I do not profess to be an expert on, stretching or PNF stretching or any of that stuff. So I that's why I hesitate to answer. It's my personal opinion based on experience and the minimal amount of work that I've read in that area.
Yeah, I would certainly agree, Laura. I like your explanation there. I wish there was more good quality research, but it would be so difficult with the multi-factorial nature of the feelings of tightness, and versus actually having muscle lengthening, and then what actually has a change in tissue length, and often it's loaded eccentrics that is sort of suggesting that may be more appropriate than, say, passive isometric type stretching and that sort of thing. But yeah, there's not a lot out there, but I agree with you. I prefer that as well.
So I love, there's this website, and they don't give me money or anything, but it's gmb.io. And they have all these, they have like a paid subscription to their programming, but they have a lot of free content, and they have some really good mobility routines. like just for working on hip mobility or ankle mobility or whatever. And it's just some really good kind of well thought out ideas for mobility. And so I've used some of those. I love the Myrtle exercises. They were designed for runners, but I actually think everyone should do them. You know, because you know, we sit a lot, right? And so then we get tightness in our hip flexors, and you know, maybe not quite using tension in our glutes to support our spine as we should. So the Myrtle exercises just remind you where your root glutes are and help to strengthen them. If you're looking for some really good hip mobility, hip strengthening, Google Myrtle exercises. There's a series of like, I don't know, 10 or 15 exercises designed for runners, but I think they're great.
Awesome, that's great. Okay, question from the group chat. So Thomas wants to know, for the exercise section, where you talk about supine presses, arm and leg extensions, he wants to know, what does this actually look like in supine?
Sorry, say that again.
So in your exercise section that you were talking about supine presses,
yeah,
with arm and leg extensions, he wants to know, what does this look like in supine?
Got it. Okay, so I'm sharing a slide right now. So you see the woman in supine, and she's doing what we call an arm lengthener. So the idea of trying to lengthen through the arm while in supine, that will activate the thoracic extensors. And then you can also kind of press the arm into the floor gently as well. You can also do like a gentle chest lift in supine. So those would be examples of thoracic extension in supine. We can also do, so I have these pictures here where she's lying in supine, but she's lying over a half foam roller. So some people will lie over a foam roller to promote extension of the spine. So that's another way to do it. And then you can add these TheraBand exercises like resisted thoracic extension as well. And then for the lumbar spine, you can, if you lie with, in this position here, where you have the knees bent and then you have one leg extended, and you can either let that leg feel heavy into the floor, or you can extend through the legs. We call it a leg lengthener. Those are ways to add a sort of lumbar extension in supine. And so this is, and the reason, like, so it's again thinking about progressions. Like some people will be able to do bird dog right away, right? But if you have someone who's got, you know, hyperkyphosis or has had a previous vertebral fracture and they have some back pain, you know, we might start with just supine lying and then slowly add some of these types of exercises so that they're doing the exercises with their spine unloaded, right? Because if you think about it, like lying down, you're unloading the spine. If you stand up, you're going to have a bit more axial load. And then if you sit, there's going to be potentially even on the lumbar spine, a bit more axial loading. So we start in the position that they're least loaded and progress them from there. So that's why I have this progression here. Where is it? Here, where we say we start with supine lying, then we add exercises in supine. And it doesn't have to be a press. It could be the arm and leg lengthener, the chest lift, but add exercises in supine. Then some people would go from supine to prone extensions. Or you could then go from supine to standing, and then or quadruped. So that's how I envision the progression in terms of loading the spine and challenge. Does that make sense?
Yeah, it does. And Thomas answered back in my group chat, said it answers his questions, and that's what he was looking for. So that's great. I have another question. So you were talking about the person who had done some martial arts and was wondering about continuing, and you mentioned about teaching, or that they would know fall mechanics because that's part of their sport a lot more than, say, the average person. Have you ever thought or tried, or is this something that you've gotten into in actually teaching people how to fall?
No, but there are programs that do that. So I think it was in the Netherlands or Finland or I don't know, somewhere where they did like a course on how to fall. And it was in the news. I remember seeing it and going, that's a pretty cool idea. But yeah, there was this, I do think it's important to coach people how to get off the floor. You know, so, and certainly any balance training, eventually I think you could progress people to reactive type movements, so that they learn. So there's a whole body of literature looking at reactive stepping as well. So thinking about reactive movements in your balance coaching, but also getting people to learn how to get off the floor. But yeah, certainly if you have the expertise to do the coaching of safe falling, that would be a cool thing as well. It's not something I really know a lot about. So yeah.
I'm kind of intrigued by the whole idea of it, because I mean, it's, you know, we talk a lot about falls prevention in a lot of different scenarios, but I mean, the reality is it doesn't, you know, we think falls prevention when we're talking about older adults or osteoporotics, but I mean, people fall all the time throughout their entire life. And, you know, I find some of the skills that I've learned through gymnastics and some of my background, wrestling and that, you know, has been huge if I slip on ice, right? You know, I sort of go back to that. And so I'm intrigued as to how that might work, but yeah, I'm aware of that group that did that, but yeah, I haven't really seen a lot of studies on that. So I think that'd be kind of cool to see how you might progress those things.
I think at the end of the day, you have to figure out like what's going to motivate the person in front of you, and you know, some people are really concerned about falls, and so if that's their concern, then I would work really on balance, on alignment, and potentially reactive stepping, and maybe coaching that type of thing. But I think sometimes we have this idea in our head that we're going to try to do all of it, and you lose people because there's so many things they have to remember and do, and they don't remember why they're doing all these things. So I think it's about, you know, pick a goal and work towards it. And if the person really strongly feels that they want to work on fall prevention, then that could be a great element. But it's about prioritizing goals and starting small with the things that we prescribe. You can also incorporate other ways of, you know, like thinking about focusing on trunk control and balance during activities that involve reactions, right? So playing catch, right? And they have to react, right? So that's also going to work on those reactive mechanisms.
Yeah. Well, that's good. So a question from the group chat. Have you yourself included impact exercises in your research, your classes that you've done in rehab? And then following up from that, how do you know what is too much for a person?
So I don't teach classes, and I do not have clients. I find that my teaching and research load is more than enough to keep me busy. But I have done studies, and the one study we just finished, we did a little bit of impact, but it was because they were pre-frail. Like we had people with assistive devices and, you know, all kinds of mobility challenges. It was really hard to incorporate any form of impact. So like I said, we had them doing things like foot stomps and heel raises, and then maybe doing heel drops where they're kind of dropping, like, and again, working on the speed of the movement. And even that was challenging and people didn't like it. So, but I think that the people that did appreciate it were those that the instructor spent some time explaining why they were doing it. So that was something we learned from our qualitative interviews of the clients. So there was 4 sites being taught by different instructors. And the one site where the instructor spent some time saying, this is why we're doing that exercise, they appreciated it. But it's something that, you know, people didn't really like all that much. And even then we weren't even really doing impact. We were more doing like the pre-impact work. So I would say that's the extent to which we've incorporated in studies we've done, but that's because a lot of the studies we've done have been in like people with vertebral fractures or people who are pre-frail or, you know, stuff like that. So I haven't done a lot of stuff in younger people. So that's probably why I do them myself, because I think they're important.
Yeah, that's cool. So I'm going to say, Nathan, who asked that question, said thanks. So that was a good answer. I agree. Just last chance for questions. I'm going to ask one more while we're waiting to see if anybody else is going to ask, and then we can wrap up. So you mentioned that you're more of a fan for for training the back extensors, you mentioned you're more of a fan of the endurance versus the strength, and I'm kind of on the fence. So
Yeah.
what's sort of your reasoning? Why are you more of a fan of the endurance versus the strength?
For back extensors?
Yeah.
I guess I just think about it like, well, I want my back extensors to hold me up all day and to be able to, you know, not fatigue while I'm trying to do my daily activities. And so my goal would be to train them to have good endurance, right? So I think it's just a logic thing for me. It's thinking about that. And also if you look at the fiber type of the muscles, they are predominantly type 1 muscle fibers. So for those muscles, so it also aligns with the type of muscle that they are. So that's why I would focus on endurance. But I mean, if you do strength type exercises for extensors, you are still going to improve endurance. So I don't think it matters that much. I think the only difference I would say is that the forces might be greater if you're using strength training. And if you have someone who has low bone mass and you're applying high forces, you could then potentially have higher compressive forces on the spine. That might be another reason. I'm not a biomechanist, so I don't profess to understand calculating the forces on the spine or anything like that. But understanding sort of at a high level, I want them to hold up my spine. I don't want super high loads on the spine. Those would be the reasons I would, and the muscle fiber type would be the reasons I would be on team endurance. But I wouldn't necessarily object to doing strength training. I think the other thing is it also depends on what exercises you're doing in your routine. So if you're doing overhead presses, I mean, you're doing back extension. And so do I need to do separate back extensor exercises if I'm already doing overhead presses in standing, right? Probably not. So I think it also depends on the programming that you're doing. So I wouldn't necessarily say, but still you could combine the endurance activity for back extensors separate as an accessory exercise in addition to the overhead press that you're doing for strength. And then you get, I guess, different types of training for that muscle group. That's probably a pretty confusing answer. Sorry.
I followed. Hopefully everybody else did too. I agree. I think there's you could look at it from both perspectives. I think of one of the best back extensor exercises that I will ever do is any sort of form of bent over rows where you're unsupported. Like those are, to me, assuming the person, which is, as you said, assuming the person has the right form and can maintain the form and doesn't lose the form. To me, that's one of the best ones, which is a combination, right, of endurance and strength. So and probably as you mentioned, in the more functional manner, being sort of a whole body type exercise. So
you just might not get the thoracic mobility, and like you might get a lot of lumbar extension, but not as much in the thoracic spine. So you might need to add a separate exercise for thoracic extension and mobility, to complement that, right? Because if you're doing it, especially if you do have a little bit of hyperkyphosis, then that will affect your leverage as well, right? So
yeah, totally. Yeah. So, and then in your answer, you mentioned just a little bit on compression of the spine with sort of some of the strength type exercises. I always struggle with this, and I don't think that there's a good answer biomechanically based on what we know to date. Putting force and pressure and stress through a system is what causes it to adapt, but then you do too much, and that's what can cause injury. I mean, is there a rationale maybe for doing some compressive loading in a progressive overload type
absolutely
manner?
No, I think it's just walking that line, and it depends on the person in front of you. So we had a woman in one of our studies who fractured a vertebra bending over to put on her shoes, right? So I need to walk the line of how much load I'm going to put on her spine because it's fragile. So I'm talking about thinking about these people who have low bone mineral density, and a vertebral fracture can cause pain and disability for these people, especially if they already have them. So in those folks, I'm going to be a bit more cautious about progressing that load, right? In people who have very healthy spines, I still want to be mindful, but I'm, less worried about, the forces on the spine just doing a back extension exercise, right? So you know, because maybe they can tolerate it a lot, and some movements are self-limiting, right? People will stop if they're finding that they're too fatigued. But I think that what might happen is that the fracture might happen before the muscle fatigues in someone who's very weak. So that would be my worry. So that's why we tend to start with, you know, back extension exercise in people who are high risk. We start them in the least loaded position and progress them. At least that's what we teach in Bone Fit.
Yeah, that's awesome. Okay, well, I think we'll wrap up there. But Lora, thank you so much again for coming on the Strength Jedi Council. And it was, like I said before, it was, you know, really fantastic to get the blend of research and practice, and that really means a ton to me that you did that. And thanks for taking your time and expertise to let us know about this. So.
No problem, no problem. Happy to answer questions if people have them afterwards as well.
Okay. Well, Lora, you had your contact information, I think, on your first slide. If I remember
I think
correctly.
It's on my last one.
Oh,
Let me
your
just
last
see
one.
here. Where is it? Okay, now I can't find it.
It's as long as it was on there somewhere.
I must have deleted it somehow. Oh yeah,
Well,
I did. Look at that. Hold on, I'll share it here.
What's the best way to get a hold of you? By email or?
Yeah, email is probably the best. I share it there. There it is. So my email is there, and I'm on Twitter as well.
Okay, perfect. So thank you very much. Yeah, thank you for offering to answer questions after the fact as well. And yeah, so we'll end it there. And have a great day, everybody. Thanks again, Lora. And I know you and I will talk soon.
Hey, I have one more thing to plug. If you are a person that treats people with acute vertebral fractures, we might be doing some interviews with healthcare providers that do that. So if anyone might be willing to be interviewed, please let me know.
Awesome. All right. Thanks, everybody. Thanks, Lora. Take care.
Thanks. Bye.
Bye.